All right, welcome back, everyone. My name is Diane Martin, and I'm the director of the Geriatrics and Gerontology Education and Research Program at the University of Maryland, Baltimore. And we are so happy to be part of this annual Caregivers Conference that the MAC on the Eastern Shore puts together every year. This is our fourth webinar in our Navigating Dementia education series that is funded with generous support from the Maryland Department of Aging. A reminder that this webinar is being recorded, and the recording, along with our resource book, that if you are participating as part of our Navigating Dementia, you should have received the resource book yesterday. Both will be made available in our new on-demand library that will be opening later this summer, and we'll send you some information about that when it becomes available. The title of this panel discussion is Spectrum of Services and Supports in Maryland for Persons Living with Dementia, and it is designed to provide insights into the array of long-term services and supports essential for individuals living with Alzheimer's disease and related disorders throughout the progression of their illness. The objectives are to identify services and supports available through the Maryland Department of Aging and other community providers across the state, to understand that people with neurocognitive challenges and their care partners have unmet needs, many of which are non-medical, to apply a framework for designing an effective referral plan that addresses what matters most to the person living with dementia and their care provider, and finally, to evaluate the quality of care referrals delivered and received. We have 5 panelists presenting today. First, you'll hear from Amanda DiStefano, who is the Long-Term Services Division Director at the Maryland Department of Aging, where she works to change the trajectory of aging by helping Maryland residents live healthy, active, and independent lives in the community for as long as possible. She is a certified community resource specialist specializing in aging and disability resources and has 22 years experience in education, public health, injury prevention, and aging and disability resources. Her passion for improving quality of life for older Marylanders have led Amanda to her current role. Welcome, Amanda.
Thank you so much. Let me just share my screen here and we'll get started. I'm assuming everybody can now see my slides. Great. Perfect. So my name is Amanda DiStefano. Thank you, Diane, for the introduction. I am the Long-Term Services Division Director here at the Maryland Department of Aging, and I was invited today to do an overview of what we have to offer at the Maryland Department of Aging and ways to connect to the services and supports available. So that is the objective of this presentation. I always like to start presentations that I do with sharing a little bit more about the Maryland Department of Aging. I feel like sometimes many people don't know the Department of Aging is here and what we do and sort of how we advocate and support across our state to improve the lives of older adults and those living with disabilities in our communities. Our mission at the Maryland Department of Aging is to prepare Maryland for a growing population of older adults by serving as the leader and catalyst for innovative approaches, multi-sector collaboration, and equitable access to resources. In a nutshell, what that basically means is that we're providing advocacy and support to older adults living in Maryland. We do that through informing the legislative process, developing programs, supporting our network of area agencies on aging in implementation of programs and supports, and a wide variety of community collaboration and partnership to ensure that aging is part of the conversation across the sector and across our state. In Maryland, our population is aging. It is projected that by 2040, 26.57% of our population will be over the age of 60. For the first time in history, the number of older adults in this nation exceeds the number of school-age children. Why does that matter? Well, that means that we need to be prepared to help individuals who are aging in our communities to age well, right? We need to start thinking about the way that we think about aging in this state. Our vision for Maryland's older adult population is that all older adults are entitled to lead lives that are healthy, financially secure, socially connected, and purposeful. That's a big order to fill, right? There's lots of things that we're doing to try to help address or achieve this goal. We want to help people prepare for the 100-year lifespan that's projected. It's estimated currently that all 5-year-olds, many of you in this room probably know a 5-year-old, a grandchild, a child, a neighbor. All five of all of the 5-year-olds living in the state of Maryland currently, it's estimated 2 in 5 of those will live to be at least 100 years old. So that's something that we need to be thinking about and preparing people for the longevity of life, so that they can meet those, being healthy and socially connected and having a life that's meaningful to them. Some of the ways that we do this are through several focus areas, and these are just some of the things that we're focusing on here at the Maryland Department of Aging. We have programs associated with elder justice to help individuals who are living in the communities age well, and protect their rights and understand their rights as they age. Some of the programs that are related to elder justice are things like our ombudsman program. Ombudsmen provide advocacy support and education to individuals who are living in a nursing facility or an assisted living. You have a loved one who is in a facility and you're concerned about their resident, you're unsure what their residents' rights are, or you're concerned about their treatment and need someone to help you navigate reporting neglect or abuse. Our ombudsman program can help you do that. We also offer legal clinics in each of our area agencies on aging to help individuals establish powers of attorney, advanced directives and things of that nature, and really plan for end of life. We offer programs that support victims who have been victims of financial exploitation or abuse and neglect, sort of navigate after what that might look like and help them get to connect to resources and supports following those, that type of abuse and neglect. Information and or access to information is sort of where we're going to spend most of our time focusing on, but for information and access to information, we have a program called Maryland Access Point, which is our network of aging and disabilities resource centers here in the state of Maryland, that helps individuals connect to resources, services, and supports to address their comprehensive, holistic needs. Health and wellness programs are things like our home delivered meal program, our congregate meal programs, as well as things like evidence-based programming for addressing needs of individuals like chronic health disease management, living well with diabetes, or living well with chronic diseases. There's fall prevention programs. There's a ton of family caregiver support programs offered through our network of area agencies on aging, as well as the senior centers across our state. Aging in place programs are things like programs that can address the needs of individuals and fill gaps in services to help individuals remain in the community for life, and really divert the need for a more institutionalized care setting for individuals. And we do all of this in partnership with many other state agencies, community organizations, and so we focus on partnership for funding and for advocacy and for support, for identifying gaps and really filling those gaps and needs across the state. As I said just a moment ago, we're going to spend a lot of time during this presentation today really focusing in on Maryland Access Point, because Maryland Access Point is really how you access the full range of services available through the Maryland Department of Aging, the AAA or Area Agency on Aging Network, and really can gain access to information, assistance, and referral that you may need, or have patients or clients that you may need to connect to. So Maryland Access Point is Maryland's network of aging and disabilities resource centers. In that particular acronym, ADRC, is not unique to Maryland. There are ADRCs across our nation in every state. The main purpose of aging and disabilities resource centers is to really address the frustration that older adults, people with disabilities, and their family members experience when they are trying to connect to and or learn about the long-term services and supports that exist in their community to address individuals' needs. We help through Maryland Access Point to raise the visibility of the full range of services and supports to help people be able to make more informed decisions about their service needs. Additionally, we help people access public and private programs. So we're not just connecting individuals to state or federal benefits. We're also connecting individuals to grassroots community organizations and supports and programs that might exist in your local areas that are unique to your communities. We do all of this in a very unbiased way, so there's no commission involved. All of these programs are offered at no cost to the individual, and we provide reliable information and counseling to anyone, regardless of income. What ultimately is MAP? MAP is for getting information and referral, information about long-term services and supports, and referrals to programs, services, and supports that can address the needs of an individual living in the community. It is also for getting access to or assistance with connecting to available resources. Navigating the system, even when you understand the system, can be really difficult. You know, everything has a different application process. There may be certain steps that you have to take, and our role is really to kind of help streamline that process and help you understand what you need to do to effectively connect to the services that you need. This is a person-centered process. So MAP is also a person-centered options counseling and support service. We provide all of the services with the individual in mind to ensure that the needs, wishes, desires, and wants of the individuals that we're serving are being addressed. It's also for planning and developing action plans to address long-term services and needs of an individual. Ultimately, what Maryland Access Point is not, MAP is not crisis intervention. So oftentimes, you know, people will call us when they have a crisis. You know, I don't have a meal for today or a bed to sleep in tonight. We don't provide direct service. So oftentimes we can't give you that meal or provide that bed immediately, but we're going to point you in the right direction to help you address that need. We're also typically not same-day service because determining eligibility for many of the programs, benefits, and services that we connect individuals to does take time. There's an eligibility application process, an eligibility determination process, and enrolling in programs can, as you know, can take time, energy, and effort. So we always encourage people to reach out to Maryland Access Point before you're in crisis, before you need us. It is also not really meant to be case management, although some of our Maryland Access Point offices do provide quasi-case management. Ultimately, when you call in with a need, we're going to help you look at the original reason for your call, and then address other needs that you may have associated with that need and other things that you might have not thought about, and then encourage you to call us back for additional assistance as opposed to case management, which might follow you for a predicted period of time and follow up with you on a regular interval for a series of months. In order to connect with Maryland Access Point, there are several ways that you can do that. We do have a toll-free number here in the state of Maryland, 1-844-MAP-LINK or 627-5465. Our MAP-LINK number is being answered by 211. So we partner with 211 to provide initial information and assistance and referral over the phone. And then they will connect you to one of our local Maryland Access Point offices for more in-depth assistance. You can also connect with MAP using our website. We have a dedicated Maryland Access Point website that you can go to for information about a wide variety of programs and services that exist, and to learn about how you can connect with each of the local offices across the state. You can also connect, obviously, by reaching out to one of the local MAP offices in person or by phone. There are 20 MAP offices across the state serving all of Maryland's counties. The information that you see on the screen is a little small, so it may be hard to read the telephone numbers, but you can also find that information on the website. And I believe these slides will be shared with everybody following today's presentation. Maryland Access Point offices are typically located as in each of our area agencies on aging, as part of senior centers across the state, and are open to the public. So you can walk in and request an appointment. You may not get a same day appointment, but you can schedule appointments for one-on-one visits with our MAP staff. You can also interact with MAP staff over the phone. One of the core functions, the core services offered through Maryland Access Point is information assistance and referral. It is person-centered information, access assistance, and referral for a wide variety of community-based services and supports. You can refer individuals who need assistance with financial benefits, housing, transportation, social engagement, education opportunities or employment opportunities, legal assistance, health and wellness, and so much more. You can see, there's even more listed on my slide. Really, there's no wrong referral for MAP. Maryland Access Point is really about helping, as I said, individuals understand the full range of services and supports that exist to address the needs of individuals in a very holistic way. The way that we do that is through intake, assessment, and screening. As when you interact with Maryland Access Point, oftentimes you are asked of some basic demographic information as part of your intake process. You're also asked information about your income and your assets to help us assess potential eligibility for a variety of programs. And then additionally, you may participate in some screenings. The most common screening that you would engage in with the Maryland Access Point is called a level 1 screen. That's level 1 screen is a assessment to determine risk of institutionalization, or how much need is there for an individual to keep them in the community safely. Ultimately, the goal of Maryland Access Point is to divert the need or delay the need for institutionalized care. So all that we do is sort of really focused at that. We help connect people to financial benefits to put more money back in their pocket so they can pay for or offset the cost of things like personal care or respite services for their family caregivers. As a result of this intake, assessment, and screening process, we can do several things. We really triage individuals who are being added to wait lists for things like the community options waiver. We are helping to develop goals associated and actionable steps for individuals to take around their long-term care needs. We're also making a referral, as I said before, to a wide variety of programs and services to address the needs of individuals that we interact with in a very holistic way. And we provide application assistance and support. So it's not just, here's the telephone number, figure it out. We really kind of help walk people through the process of applying for a benefit and follow up on, next steps that may be necessary to connect successfully with those programs and services. One of our big functions for Maryland Access Point, in the state of Maryland, we serve as what's called a no wrong door. We're the one-stop shop, if you will, for all things long-term services and supports. And one of those things that we connect individuals to are Medicaid waiver programs. Maryland Access Point, as I said, does that level 1 screen, and the level 1 screen in the state of Maryland is used to add individuals based on their priority or based on their needs to the Community Options Waiver Registry. That's a fancy way of saying wait list for Community Options Waiver. Community Options Waiver can really open up a wide array of services and supports for individuals through Medicaid that are funded by Medicaid. You can see all of the things that are offered through the Community Options Waiver on the screen here. So things like case management, assistance with training of family caregivers, assisted living, medical daycare, senior center plus, nurse monitoring, personal care services, the list goes on and on. But in order to access the community options waiver in the state of Maryland, if you live in the community, you cannot apply directly. You have to be invited to apply. So the community options waiver registry was established to triage individuals, and MAP is used to do that triaging. So while you're on the wait list, we're working to connect you to other programs and services to address your needs related to whatever it is that you may need help with. So if you need personal care, assistance with bathing, family caregiver respite, those kinds of things. That's sort of where Maryland Access Point comes in. We do the level 1 screen, we add individuals to the community options waiver registry, and then we help to triage them into other programs and services while they're waiting on this wait list. If any of you have ever applied for the community options waiver, you know that it takes a significant amount of time for the eligibility determination process, development of a plan of service, and to get services actually implemented. So again, MAP is really kind of there to help connect individuals to services and supports in the community while they wait for that process to start. Some of the programs that we connect individuals to are programs like senior care. The senior care program is a program administered by the Maryland Department of Aging in partnership with all of the area agencies on aging across the state of Maryland. It's for individuals who are 65 and older, who are at risk of nursing home placement. This particular program offers comprehensive screening and assessment of needs. It also offers case management and coordination of services. So individuals who are eligible for senior care do have case management, regular contact with a provider that can help coordinate benefits and services and address the needs of an individual. It also offers gap filling funds to purchase services while you wait, as I said, for the community options waiver invitation or for services to be started through that program. The services that can be purchased are things like personal care and chore services, respite care, adult day. So some of the same services that you see through the community options waiver program, you can access through senior care if you are eligible. In order to gain access to that program, you go through Maryland Access Point. Another program that we are working to connect individuals to through Maryland Access Point is the Senior Assisted Living Subsidy Program, or SALS, is what we like to call it. This particular program provides a subsidy to offset the cost of assisted living. It is for individuals who would otherwise be in a skilled nursing facility, who can't really afford assisted living and need some support. It's for individuals who are over the age of 62 and who are either in a facility already that is an approved facility or participates with SALS or is approved for entrance into a facility, who have some sort of physical or cognitive impairment that would ultimately mean that they would need to be in a facility to meet their needs. There are financial eligibility criteria for this particular program. In order to access and determine potential eligibility for this program, you start with Maryland Access Point. Additionally, through the Maryland Access Point, as well as the Area Agency on Aging network, there's a program called the National Family Caregiver Support Program, which provides counseling and education. It has a wide variety of support groups for family caregivers and loved ones. It provides respite services to family caregivers who are providing care for individuals, in their homes or in the community, and also offers supplemental services that can help, again, offset the cost of things like personal care or chore services or, purchasing incontinence supplies. This program varies from Area Agency on Aging to Area Agency on Aging. So the way that it is implemented and the way the funds are dispersed and eligibility criteria does vary from county to county. But again, in order to access this program and really understand what's available, you would connect to Maryland Access Point. just a couple of other quick programs, and I know I'm probably running short on time, so I want to get through as much as I can quickly. That may be helpful for this group to understand that are available through the Department of Aging. We have a program called the Maryland Durable Medical Equipment Reuse Program. This program is a program that is available to all Marylanders, regardless of injury, illness, or disability, regardless of age. And it is available at no cost. This program provides durable medical equipment, canes, walkers, wheelchairs, shower benches and transfer chairs, Hoyer lifts, all kinds of things. They even have some motorized wheelchairs and lots of really cool stuff. All of this equipment is collected at our central warehouse. It is sanitized, inspected, brought to like new condition, and then redistributed out into the community. It's a free in, free out program, which means all of the equipment is donated to our department, and then it goes back out into the community, into the hands of individuals that need them. So if you are working with an individual that needs durable medical equipment, I encourage you to use this program first, or look at this program first to see if the equipment can be provided at no cost to the individual versus out of pocket, or billing insurance and things of that nature. So to learn more about it, you can click on the link on the slide when you get them. Or you can reach out to the Department of Aging, or even just Google Maryland Department of Aging Durable Medical Equipment Program, and it'll pop up right away. There is an application for the equipment. There's two different types. One is more basic equipment, things like a basic wheelchair or a cane or a shower bench, those kinds of things. More specialized equipment may need a doctor's sign off, so the application process is a little bit more in depth there, but the staff at the Durable Medical Equipment Reuse Program can assist you in walking through which of the two applications you need to use when applying for the equipment. And there's also staff on hand who can ensure the equipment matches or meets the needs of the individual. So really cool program that's at no cost and is available to anyone, regardless of age. The other program I just wanted to quickly highlight is our Senior Call Check program. The Senior Call Check program is a free daily check-in call to Maryland residents over the age of 65. This particular program is really useful for individuals who are living alone and maybe need some support in the community, and could handle getting a robocall on a daily basis just to check on them. What ultimately happens with this program is individuals are called each day with a wellness message to check in on them. When they answer the call, they can say that they're okay by hitting any button on their phone and they're good to go. If they don't answer, this is sort of where the value of the program comes in. If they aren't unable to answer the phone for any reason, a call is placed to their emergency contact person to notify them that we are unable to successfully connect with the individual, to alert them to check in. If we're unable to connect even to the emergency contact person, we can even at the local level initiate a wellness check for individuals. So this particular program is another free program that is available through the Maryland Department of Aging that can really be a gap filling program to meet the needs of individuals who are living in the community and help keep them safe in the community. And with that, I'll open it up to questions. I hope I didn't take too much of the time today.
You did great. Thank you, Amanda. And did I just see a news release that the durable medical equipment received national recognition?
You did, absolutely. That program is a really kind of innovative program that was meant to be a gap filler. The need for durable medical equipment is always there. And prior to this program, all of the durable medical equipment that is donated to us was dumped in landfills. People didn't need it and they were just throwing it away. And we know that all of this equipment, has more life and can meet the needs of so many more people. So, we created a process to sanitize and make sure everything's in good working order and like new, and putting things back out into the community that would have otherwise been dumped into landfill. So this national recognition that we receive is really around being eco-friendly and
There you
saving
go.
all of that from falling into our landfills across the state of Maryland.
Yeah, great. We are going to hold off on questions until after the panel discussion. So attendees, if you have questions for Amanda about any of the programs available through the Department of Aging, you can put them into the chat box. I'll be moderating that shortly. But our next panelist is Laura Gillen. Laura is a project consultant with me here at the University of Maryland in our Geriatrics and Gerontology Education and Research Program. She is an applied gerontologist, an educator, and a care partner. Her goal is to optimize aging outcomes through education, advocacy, and translational research. Her roles in the community focus on helping others to navigate a dementia or life course journey, educating on evidence-based practices and strategies, and advocating for support and positive change. Her presentation is going to be focused on the basics of effective referral, which really aligns nicely with some of the presentations that we heard earlier this morning. So welcome, Laura.
Thank you, Diane. Good morning, everyone. I'm Laura Gillen. I'm happy to be able to spend some time with you today. I'm going to be talking about the basics of effective referrals. So our learning objectives for today are to understand that even though effective care management and symptom treatment options exist, many people have care needs that go unevaluated and unmet. Many of these are non-medical needs. So we're also going to learn how to find out what matters most to a person using a person-directed care approach. And lastly, we'll discover the basics model for an effective referral and how to evaluate an interaction from a person, caregiver, and provider lens. Our conference theme this year is Dementia, Navigating the Journey. Caring for a person living with memory loss or dementia is a journey, one that can last for many years, and it's filled with twists and turns. The journey is really not a straight path through stages. Each person with cognitive challenges or dementia may progress differently, and certainly in their own time and manner. Care partners and family who are companions on this journey will need information, support, and guidance along the way too. Most people report that they are not prepared for life with dementia and that they would welcome some type of roadmap. A map provides a look at the big picture and the road ahead and offers directions and tips about what to expect, what decisions lie ahead, and what steps to take for the best results. So a good referral offers direction and makes all the difference in finding the way and not getting lost. It's about making the connections from here to there as the need for services and support changes over time. Changes in life may cause you to need more support. Changes in general health, medication, daily routines, changes in thinking or cognition, communication, changes in daily living, sensory changes, and changes in mood. Amanda gave some information on how the Department of Aging can help with these. Here's a tip. If you're worried about changes in your memory or that of a loved one, keep notes about daily life. Write down any changes you observe, and this will be useful information for a health professional or service navigator to know about. It will provide a baseline to check back to over time or to see patterns and changes. So, what kinds of support are you looking for? Or if you're a service provider, how can you help? Here are some common needs of persons living with dementia and their carers. Persons living with dementia, their care partners, and families need support. Maria Shriver, founder of the Women's Alzheimer Movement, spoke recently about access to care. She noted the need to be determined, relentless, and a fighter to get the care you deserve. This needs to change. Using the Johns Hopkins Dementia Care Needs Assessment, we found that unmet needs in our community are extremely common, modifiable, and non-medical. Non-medical needs include number one, home and personal safety. 98% of people who responded to the survey said that these needs were unmet. Delegate Sample Hughes talked about how the state can help to provide things like grab bars and screen doors for safety for eligible residents. Other needs were for caregiver informal support, meaningful and daily activities, neuropsychiatric behavior management, medical condition management, and caregiver mental health. An important point is if we aren't meeting these needs for the person with dementia, caregiver burden as well as costs will also increase. So let's get down to the building blocks of an effective referral for services and supports. First, know the person living with dementia. Think about how you feel when you walk into a place of business and they know your name. They know how you like your coffee or sandwich, and they let you know at Chick-fil-A, it's been a pleasure to serve you. This is not a one-size-fits-all approach, is it? The individual living with dementia is more than the diagnosis. It's important to know things like their values, beliefs, interests, abilities, likes, and dislikes, both past and present. So we need to build and nurture caring relationships. We must validate feelings and concerns and connect. Every interaction is an opportunity to literally change a person's life. This is the deep meaning behind the work we do as care partners. Treat others with dignity and respect. Be present and concentrate on building a relationship rather than checking a task off the list. Take the time to pause, reflect, and then evaluate what you are doing and make changes when needed. Let's talk about the basics model and how to use it as a way to provide a successful referral for services and supports. This information will be useful to caregivers as well. So BASICS is an acronym for a biopsychosocial model for providing care. Each level represents a level in the hierarchy of needs, which is a model for what humans need to thrive. These needs grow from the simple to the more complex, from biological up to symbolic. We are motivated by our needs as human beings. How we act is often controlled by what we need. Have you ever been hangry? It's impossible to concentrate or continue on until you have something to eat, right? Ever been scared at night? It's pretty hard to relax until you feel safe again. So let's look at this slide more closely for a moment. The most basic needs of humans are biological: food, water, oxygen, safety, rest, human stimulation. If biological needs are met, there's a sense of self-preservation. The person will feel physically cared for and safe. If these basic needs are not met, what happens? A person is unable to thrive. Without these things, life will end. Next, activities of daily living are things we accomplish that show we are independent and we can do for ourselves. Eating, moving around, getting dressed, using the bathroom, taking care of our personal hygiene. Think about this, on the other hand. How does it feel when someone treats you as if you don't know how to do something that you do know how to do? Not great. Next are societal needs. For a societal need is each person feeling valued and respected. Here's a question to think about. If you are never asked to offer an opinion about a decision affecting you, would you feel valued and respected as a person? Our interpersonal needs are the need for connection with others. This involves things like the roles we have in our life: father, grandfather, coworker, feeling confident and feeling cared about, as well as caring for others. On the creative level, humans enjoy creating, problem solving, and experiencing joy. Anyone here do Wordle or crossword puzzles, draw, or play music? How can you tell if someone is experiencing joy or happiness? Well, have you ever seen a person's face light up? There's a spark of life there. In a very simple way, you might experience joy when you hear a funny joke. My elementary school age granddaughters love to tell jokes. Here's one they told me yesterday. Why can't your nose be 12 inches long? Well, the joke is because it would be a foot. Our symbolic needs are needs to express beliefs, hopes, dreams, values, our spirituality, and also to control important aspects of life. When symbolic needs are met, you may find a sense of peace in the universe. All is well. You're being all you can be. These are also the things that make life worth living. If some of our most important needs are unmet, then we may be unable to progress and meet our other needs. This can help explain why we might feel stuck or unmotivated. If our critical needs aren't being met, it prevents us from being the best possible version of ourselves. So this is a slide that examines the basics model from what we can do as a service provider or caregiver and how we can support others through our actions and attitudes. Remember that every referral, every interaction is truly an opportunity to change a person's life. Let's review these goals of care. The most simple need, the biological need to feel safe. We ask ourselves, is our tone that we use with others warm and caring? Is there a sense of trust in that relationship that we have? Second, our actions and attitudes help a person to feel comfortable. Does the person have their hearing aid, their glasses? Are we providing a comfortable setting for them? Next, our actions and attitudes will permit a person to experience a sense of control. Are we offering choices, asking opinions of the person? Do we provide cues for success, or do we just jump in and do it ourselves? Think for a second about a loss of sense of control and how that would feel. How would your situation change, for example, if you could no longer drive yourself where you needed to go? Next, do our actions and attitudes help a person feel valued? Do we make an effort to know about the person we are serving? Do we listen attentively without interruption and offer enough time for a response? Are we respectful? Next, do our actions and attitudes encourage others to use their talents, skills, and abilities to the highest degree possible? Do we allow a person to do as much as they are capable of? Or do we intervene in the interest of getting things done quickly or checking an item off our list of to-dos? Do we ever offer a chance for a person to be a leader in a situation? Lastly, will the person experience joy or fulfill a dream as part of how we support them? Sorry, I don't know what happened with that. Do we offer something as simple as a joke or a laugh, a compliment or encouragement, or praise for persevering through a challenging situation? So now that we know the basics of what a person needs and how our actions influence quality of life, how can we provide the best referrals, support, and services? After an encounter with us, a person should be better off, right? In a sense, they should feel as though they have received a gift from us. There are three parts to a good referral: knowledge, attitude, and action. You can look at these goals from the perspective of both the receiver, in this case, the person living with dementia or a care partner, or the provider, and that's anyone who's offering service or support. First of all, knowledge should increase through a successful referral. We should ask ourselves, is the information I'm offering or receiving relevant to my current situation? Is it good quality information? And does everyone understand the information? Next, attitudes should improve through a successful referral. We should ask, can I trust this advice? Is this information different than what I've heard elsewhere? Will this information help me to be more confident? And lastly, as a person living with dementia or a care partner, we should have that roadmap or a game plan for what we're going to do next. Do you have at least one person you can call when you have an urgent need? Do you have enough help to meet your current needs? This can include questions like, can I get to that appointment? Can I fill out the forms? How much will this all cost? And lastly, will this help me to prepare for future needs? So let's review the basics of an effective referral and why it's helpful. You might be asking yourself now, what is special or different about working with a person living with dementia? So this list is drawn from a study that was done through a survey of individuals living with dementia over the 10 years of the Alzheimer's Association Early Stage Initiative. They said the most important thing is to get to know us as a person. Give a person the opportunity to tell you something about themselves you wouldn't necessarily know about their life, hopes, and dreams. Give them time to respond. Ask their family or care partner for more details and what their preferences are. This might also include an informal assessment of cognition that might be done over the phone. It might also include an assessment of health literacy. Next, maximize independence. Ask a person what they're comfortable doing on their own versus what activities they think they might need help with. Include the person living with dementia in decision making, and that's always at every stage. Use the teach back method to confirm a person understands what they need to do next. They need to reply back to you with what the plan is. Just take your time with this. Practice patience and compassion. This will always be appreciated. You might need to speak more slowly, repeat instructions more than once, offer information in multiple formats, or use cues to provide directions. Next, provide ongoing opportunities for meaningful living. Check to make sure needs are being satisfied. Offer choices, challenges, new experiences, and variety. A person with dementia said, quote, "This could be the best time of my life. I don't have to spend all my time just remembering my past," unquote. Ensure coordination among those who provide care. Ask questions, conduct surveys, review previous medical records, and talk with family and or care partners or the caregiver. You'll need to check back, check in, and reconnect to make sure the plan is going smoothly. Use current evidence-based strategies. Train your staff to be able to share the benefits and risks of a particular service or intervention using plain language and simple examples. There's an evidence-based tool called the CASI-DEM, which measures dementia literacy and is used to determine support needs. The ability to locate, navigate, and use dementia services and information, either for oneself or in providing care to others, is an essential component. There are 5 factors which are part of an effective referral, and 4 of them deal with confidence. Confidence in evaluating information and advice, confidence in feeling ready to access appropriate information and supports, and being prepared for changing needs over the trajectory of the dementia. Personal assessment is being able to find the support from the community and friends that will increase resilience and reduce loneliness and isolation. Confidence in setting up a plan which coordinates specific dementia related services. And finally, confidence in the practical aspects of physically navigating care. Confidence is key. It helps us to feel ready for what is ahead. And if things don't work out at first, it helps us to try again. We all need that dementia roadmap and guides to help us navigate the journey. Amanda offered this information about contacting the Maryland Access Point. It's called MAP. It's the place where older adults can turn to find trusted information, supports, and service options in their area. Be sure to join us for our next Navigating Dementia webinar on May 24th at 1:00 p.m. It's offered free by the Geriatrics and Gerontology Education and Research Program, GGEAR, at the University of Maryland, Baltimore, and the Maryland Department of Aging. The theme is Empowering Caregivers, Essential Resources and Supports in Maryland. This live interactive webinar will provide information about caregiver resources, how to access them, all these things available throughout the state of Maryland. As part of that May 24th webinar, a presenter from the Centers for Medicare and Medicaid Services will talk about the new guide model of care and its implementation. Last year, Centers for Medicaid and Medicaid Services announced a new voluntary nationwide model guiding an improved dementia experience guide. It focuses on dementia care management and improving quality of life for people living with dementia. It will help to reduce strain on their unpaid caregivers, enable people living with dementia to remain in their homes and communities. Achieving these goals will happen through a comprehensive package of care coordination and care management, caregiver education and support, and respite services. The model provides 24/7 access to a support line, as well as caregiver training, education, and support services. To reduce disparities in access to dementia care services, the guide model incorporates policies which enhance health equity by ensuring that underserved communities have equal access to the model intervention. Thank you so much for your attention today and for all you do to help others navigate a dementia journey.
Thank you so much, Laura. Lots of great information. Again, we're going to hold off on questions until the panelists have all presented. So that you don't forget your questions, please put them into the chat. You can put them directly to me if that's what you'd like to do, or put them out for everybody, that Laura and Amanda and our other presenters can start thinking about the responses as well. Our next presenter, our next panelist is Lauren Blair, who will present on the facts behind common misconceptions surrounding hospice care. Lauren is the Community Relations and Development Manager and Caregiver Academy Moderator at Coastal Hospice. Welcome.
Thank you so much for having me, Diane. I'm trying to get my video, them to allow me to share my video. I'm not sure if Mike can help out. It's not allowing me to share for some reason.
Yeah, I was just checking. You do have all your permissions and everything, so I'm not sure. Looks
There
fine.
I am.
There we go.
Okay, welcome, Lauren. Thank you.
Thank you so much. Thank you, Diane, and thank you all for having me today. I so appreciate being a part of this panel, and I'm excited to share with you today. I know that there are so many myths and misconceptions about hospice care out there, and I'm very excited to share with you those facts behind them and hopefully let you know some of the many benefits of hospice care that you may not be aware of. So the most common misconception that I hear from the community or even physicians is that they think that utilizing hospice services means that you're giving up or that death is imminent. I know this is what I thought before I learned more about hospice. And so, but it's absolutely not so. We have had patients on our services for years. We even have patients who are on our services for so long that they graduate from hospice care. So we have over 100 patients per year who do so, who graduate off hospice care. And hopefully through this, you'll understand why and how that happens. So let's get to understanding hospice care first. Hospice is for persons living with dementia, aims to provide support and care to that person and focuses on quality of life for those individuals and their loved ones. And there are several core aspects of care we provide that enable us to do so. Hospice has a very person and family-centered interdisciplinary team who provides a range of services to persons living with dementia and their loved ones. We provide medication management, and medications are covered under the hospice benefit. Hospice provides any durable medical equipment free of charge to the person living with dementia, so things like walkers, hospital beds, bedside commodes, wheelchairs, even oxygen is included. Supplies, like if someone needs wound care supplies. And my absolute favorite is the caregiver training. If you are a caregiver for a person living with dementia, unless you are a nurse or an aide, you probably don't know how to properly transfer someone from their wheelchair to the toilet, or how to administer insulin, or even use a Hoyer lift to lift someone out of bed. Our team teaches all of those things so that caregivers can feel comfortable with caring for their loved ones. We are also available 24/7. So if a caregiver were to have a medication question at 2 a.m., they can call us and we can walk them through it. Or if a patient were to have a fall in the middle of the night, needs to be seen, we can send out one of our nurses to take care of them. So when a person with Alzheimer's or dementia comes onto hospice services, that person and their loved ones are then surrounded by a team of experts who care for them. The physician oversees all care, orders medications, collaborates with the patient's primary care provider or specialist. And that is another thing to keep in mind when someone is on hospice care. They can keep their own primary care providers. They also can keep their own specialists, and we can collaborate with them on the best possible care for that patient. Our nurses provide care, support, and education to patients and families. They develop plans of care and manage symptoms such as pain or anxiety, shortness of breath, whatever the patient is facing at that time. Our certified nursing assistants provide healing personal care and assist with activities of daily living, such as bathing or dressing, feeding, grooming, getting someone in and out of bed, those sorts of things. Our social workers provide emotional support for patients and families. They link patients to support services such as veterans benefits or long-term care benefits, and end-of-life planning, such as assistance with advanced directives, the MOLS form, even funeral service preparation. Our spiritual care, they provide companionship or a calming and supportive presence when patients with dementia are struggling with spiritual distress or anxiety. They can read scripture or pray or sing hymns with patients, provide communion, or assist with other faith rituals or sacraments. They can help the patient, the family, secure someone from their own faith tradition to provide support, or even just be there as a sounding board and someone to provide just some companionship with the loved ones. Bereavement helps with the development of coping skills that are necessary for families in taking care of themselves while grieving. And that's provided for 13 months after. And the reason why we do 13 months is because then we can be there for every first holiday without that loved one, the first Thanksgiving or the first anniversary of the loved one's passing, just can be extremely hard. So we're there to provide assistance with that. We also provide a variety of therapies. Another myth I hear from the community is that hospice is giving up and that you're no longer working on getting stronger or better in any way. The fact of the matter is that hospice does provide therapies. We had a gentleman whose whole reason he came on to hospice services was that he wanted to get stronger so that he could ride his motorcycle one last time before he passed. And we got him some physical therapy, and this man was able to ride his bike several times before he passed away. We provide not only physical therapy, but also occupational therapy. We had a lady who, in order to be able to stay in her home, she just needed to be able to transfer from her bed to the bedside commode without assistance. And occupational therapy helped her with that. We also have speech therapy, even music therapy, and pet therapy, all of which is because we want to enhance the quality of life for those that we serve. And of course, our wonderful volunteers. We have volunteers who can visit with patients in their homes, read a book or play cards or simply chat, or provide some respite visitation so that the caregivers can have a break or get their hair done or go to the grocery store or go to their own medical appointments, whatever the case may be. Another misconception I often hear is that hospice is a place. People say, I don't want to go anywhere. I want to stay at my home. But in fact, the majority of hospice patients are seen right in their homes. We actually focus on keeping patients in their homes if that's what they desire, which many do. We know that more than 80% of Americans say that they would prefer to die at home, but in actuality, only about 25% of deaths occur at home. With hospice care, that number of deaths occurring at home goes up to 75%. And of course, the hospice team is available to help every step of the journey with any transitions that are needed along the way. In addition to patients' homes, we are able to provide care across all care settings, so nursing homes, assisted living communities, the hospital, hospice inpatient centers, which I'll talk more about on the next slide, even places like correctional settings and homeless shelter, wherever the patient is located. The reason why I'm here working for hospice today is because of my passion for working with dementia patients in a nursing home. Prior to this role, I was the director of a memory support program at a nursing home. And during that time, I found myself referring so many of my patients to hospice, not just for the help that it provided to my patients and our nurses and aides with things like bathing and dressing and feeding, but also the wonderful support that the caregivers received. As caregivers, family caregivers, our brains may be going through 1,000 miles a minute. There's things to think about, such as finances and end of life planning and anticipatory grief, which we'll also talk more about later. And the hospice team is really able to provide help with all those things, no matter where the patient is located. Additionally, hospice offers a variety of other services. At Coastal Hospice, we have 2 inpatient units. This differs from hospice to hospice, but here locally at Coastal Hospice, we have the Mackie and Pam Stansel House in Ocean Pines and Coastal Hospice at the Lake in Salisbury. Coastal Hospice at the Lake is our short-term inpatient facility. It's located in a wing at Deer's Head Hospital. It is designed to give patients a temporary stay when intense medical care is needed to treat symptoms that can't be managed at home. So things like intense pain or nausea and vomiting or agitation. Think of it like as an ER for hospice patients. Now, Paul mentioned at the beginning of the conference the need for respite care. It's huge. The hospice benefit pays for respite care. So they actually pay for a 5-night stay at an inpatient facility to give caregivers a much needed break. And people can utilize that over and over again. Some use that time to get errands taken care of or go on a trip or take care of their own health needs. We've had many caregivers who utilize this monthly. So we know that every 3rd weekend of the month, Mr. Smith will come stay with us at the lake so that his caregivers can go visit their grandchildren the next state over. This is a great way to avoid caregiver burnout, which is so real. We also can accommodate routine home care at the lake. The wing is small, so care is very intimate, very immediate, and friends and family are welcome to come anytime, day or night, with unlimited visiting hours. And we also have the Mackie and Pam Stansel House in Ocean Pines. And the Stansel House offers everything that the lake does. So the general inpatient care, respite care, and routine home care, as well as residential care. So yes, we do have some patients who actually live with us at the Stansel House. It is a beautiful facility right on the bay. There's 12 private patient rooms and plenty of indoor, outdoor spaces for family and friends to gather, meet, and dine together even. Now, one of our very special services we provide is our We Honor Veterans program. And veterans who come into our care receive a special visit to honor them, along with a personalized certificate and a patriotic blanket donated by the community. We assist veterans and family members in enrolling and accessing VA benefits, coordinate care with the VA and other healthcare organizations. And we work with area veterans organizations to arrange color guards, and we attend special events honoring veterans. Who pays? This is another hot topic when it comes to misconceptions about hospice care. I hear people say that, oh, all that care that you provide has to be so expensive, but actually, hospice care is a benefit through our insurance. So Medicare, Medicaid, private insurances all cover hospice care. We wouldn't forego our Social Security benefits, so why would we forego our hospice benefit when we've already paid into it? If someone does not have insurance for any reason, then we accept private pay, and we also have charity care. So no one is ever turned away regardless of their ability to pay. We have wonderful donors who support us so that we can take care of every patient who comes to need us. And we also do fundraisers throughout the year. And we have a thrift shop in Berlin, which also raises funds for our charity care. We offer many additional services to the community as a whole. You don't have time to hear all of the amazing services today, so I'm going to stick with just a few here to be sensitive to our time. But we can assist in completing the 5 wishes, which is an advanced directive that covers personal, spiritual, medical, and legal wishes all in one document. So if any of you are an agency or a group that you might be involved in, if you think that they could benefit from us coming out to do a 5 wishes training, please have them reach out to us. We would love to schedule something with them. My contact information will be coming up towards the end of the presentation. Would love to come out and visit you. We also have our Coastal Caregiver Academy, which provides free in-person programs and webinars with a wide range of topics like how to have difficult conversations and approaching end-of-life signs and symptoms, palliative care versus hospice, various dementia topics. And many of those programs offer free continuing education credits for social workers, nurses, and physicians. So I invite you to check out our website to learn more about that and see our upcoming programs. We also provide free bereavement care to anyone in the community, whether or not that they have had loved ones affiliated with hospice services. So we talked some about the bereavement care for patients' families, but this is for the whole community. So if you or someone that you know has lost someone, please reach out to us. We can provide support via a call, a visit. We can connect them to a group setting or a memorial gathering in the community. We do specialized groups for topics such as loss of a parent or loss of a spouse, even loss of a pet. Again, it's completely free to those who have lost someone. So when should someone be on hospice? Some of the indicators that a person may be ready for hospice are when you see them have an increase in hospitalizations. They're going out to the hospital more, going out to the ER, and possibly getting hospitalized. Infections that keep reoccurring, weight loss or poor appetite, frequent falls or weakness, a decrease in blood pressure, pain, edema and swelling, or an increase in calling EMS in order to even help them get up. Once a physician feels that they would not be surprised if the patient were to pass away within the next 6 months, the patient is appropriate for hospice services. That doesn't mean that the person is absolutely going to pass away with that time frame. It just means that if the diagnosis follows the course that it's known to follow, that may be the case. But again, we have patients on our services for years. We have patients come off of our services very frequently. And it's just a benefit that we can all utilize when it's appropriate for us. So the admissions criteria for hospice care is that a person must have a life-limiting illness with a prognosis of 6 months or less if the disease takes its normal course. So they must also consent to accept services, or if they're unable to make their own decisions, their loved one or designee would consent. Besides Alzheimer's disease and dementia, some of the other diagnoses that might qualify someone for hospice care are dementia, cancer, heart disease, pulmonary disease, chronic renal failure, stroke or coma, Parkinson's disease, ALS. To make a hospice referral, our direct line is listed here. It's 410-742-7878. We accept referrals 24/7, 365 days a year, and anyone can make a referral. It doesn't have to be from a physician or nurse. In fact, most of our referrals actually come from family members or friends, or even from patients themselves. Some of the other myths that I hear are that patients must be a DNR in order to utilize a hospice, a DNR or a do not resuscitate. But this is not true at all. Patients can remain a full code while on hospice care. We also hear that patients must be bedridden in order to come onto hospice. This is not true at all. Think about that gentleman that was out riding his motorcycle. He was certainly not bedridden. He was enjoying the time that he had. We hear also that people think patients can't have tube feeding while on hospice. They absolutely can. People sometimes are under the impression that as soon as they sign that paperwork to begin hospice services, that they can never return to medical treatment once they're on hospice. But this is a myth as well. If I started hospice today, I could change my mind tomorrow and go off services. If I change my mind the next day, I can go back on. It's my care and I can decide how I want that provided to me. And then finally, I'm sure we have all heard this, hospice means someone will die very soon. It means someone only has 3 or 4 days to live. And this is a myth. This does happen. And that's because often patients are referred too late and they could have come on to services much earlier with us. But studies actually show that patients live longer when they're on hospice services, approximately 29 days longer than those with similar diagnosis who do not choose hospice care. And that's because they're getting the care and the supervision that they need where they're most comfortable. Hospice and dementia care. So there are many benefits to having hospice care for persons living with dementia. Many people living with end-stage dementia frequently visit the doctor's office, emergency room, and hospital due to worsening symptoms. These conditions can be prevented or managed with hospice. A 2022 National Health and Aging Trends study found that those with dementia who were enrolled in hospice had a higher perceived quality of care compared to those outside of hospice. Also, our loved ones benefit greatly. We begin to grieve the loss of a person living with dementia when we notice the decline or even when they receive the diagnosis. And that's called that anticipatory grief that we mentioned earlier. And the anticipatory grief is a grief that happens before death. So many of us assume that we're going to feel grief after death. We expect that, right? But we may be surprised by grief that occurs while the person living with dementia is still with us. Many dementia caregivers are grieving several losses all at once. You know, we talked earlier about all of those challenges that caregivers face. You know, they're facing the loss of a companion or financial insecurity or lifestyle changes or loss of employment, loss of sleep, less alone time, less time with family and friends. But understanding anticipatory grief can help caregivers process their experiences, grieve losses, and stay connected to the person with dementia. And our hospice team is there to help every step of that way. And another huge benefit is the help provided to caregivers. The Alzheimer's Association found that more than 11 million Americans provide unpaid care for a family member or friend with dementia. 11 million, that's a lot. We discussed earlier the work of the hospice team. We are there to help caregivers, again, with things like bathing, dressing, feeding, emotional support, symptom management, all those things so that caregivers don't have to go through that alone. We're here to help. One last resource I want to share with you is the Dementia Care Resources Patient and Caregiver Guide. I have had the honor with working with the National Partnership for Healthcare and Hospice Innovation, or NPHI, over the last couple of years, where we have developed now 2 guides for dementia care resources. And I want to share this one here with you today. Something that our small group from all over the country saw as a common issue in dementia care was the need to centralize all of those dementia care resources into one comprehensive guide. And this has allowed us to provide tools, tips, and tricks for dementia symptom management and increase the support for caregivers of people living with dementia. The second guide that we are just completing and will be rolling out in June is our Dementia Care Provider Guide. And this one will focus on educating the physicians working with persons living with dementia and their families. You can access the Patient Caregiver Guide on our Coastal Hospice website listed here. And you'll be able to access the provider guide in the same place once it rolls out this summer. There's a ton of great resources in these guides, and I hope that you'll be able to use them in your practice or with your loved ones. I'll share my references with you here today. A lot of great references and resources out there. And please, if I can help in any way, I would love to chat with you more. And there's my contact information.
Hey, thank you so much, Lauren. That was wonderful. Lots of great resources, and I love myth busting. So thank you for that as well.
Thank
Again,
you.
we're going to hold off on questions until after the panel discussions are done. Next up, we have Kathy Mutzberg, who is going to present on connecting caregivers to adult services and supports. Kathy is with the Wicomico County Department of Social Services and serves as the supervisor of adult services, where she oversees investigations, continuing adult protection, guardianship, social services to adults, in-home aid services, project home provider, project home resident, and respite services. Welcome, Kathy.
Thank you very much. Good morning, everybody. First of all, I just wanted to say that generally with dementia patients and looking at this from that role, we do investigations, first of all, but our role, like everyone else's role, is to have people stay in the community as long as possible. The biggest issue is being safe. There are a lot of resources that can be used. We've seen quite a few creative ways to handle people who have memory loss in the community. Nowadays, you could do video cameras. There's a lot of ways for people to remain as independent and as well cared for as possible in their home. And that is our wish. So I want to say that just because someone is experiencing some memory issues, it doesn't mean that they have to leave their home. This is why people should reach out for resources. So through the Department of Social Services in your county, wherever you may be listening from, you can access investigations, which is the adult services. Most of the time there's a local number or there's an 800 number, and you would get into the screening unit who takes the general information regarding the person that there's concern about. We investigate abuse, physical abuse, sexual abuse. We investigate neglect. We investigate financial exploitation. And we also investigate self-neglect, because the individual can have issues, whether it's dementia related or not, that inhibits their ability to care for themselves well. As far as the investigation piece goes, our role is to establish and to determine vulnerability by our standards. We have a little bit different definition of vulnerability than others may think. There's a lot of people that we can all be vulnerable to something, a car accident, being mugged, all these types of things, but our vulnerability is different and more specific to the inability to help themselves. The other thing that I want to say is that people have the right not to take good care of themselves. And unfortunately, we see that all the time. I'm sure most of you see that too. But this is us working with adults who are allowed to make choices, whether they're smart choices or not. So we do want people to stay in the least restrictive environment where they're safe. So through this process of an investigation, we would look at safety factors. One of the big things sometimes with dementia is when people start to wander and they're not familiar with their surroundings, they're getting lost, or they may be wandering at night, or wandering in the cold looking for something because of their confusion. Those are big red flags. But there are some people who have dementia who can function quite well in their environment. So we take all of that into consideration. Our investigations have to be concluded within 60 days. So we do not have a lot of time initially to get out there and get a lot accomplished. Although we can get a lot of things done, sometimes we rely on our continuing investigations. Well, they're not investigations, they're continuing APS, and they're kind of a secondary form of follow through to lower risk of people. The vulnerability piece is one piece of it. The other piece is with us, with investigations, any perpetrator would have to be a family member or caregiver. This is not, physical abuse is different than an assault. So there has to be some kind of familiar or caregiver role by the person who's maybe neglecting or financially exploiting the individual. So those are the parameters for an investigation piece. We can then go into a continuing to address the concerns that we discovered during an investigation. That is a voluntary program, but we can work with people for 6 months or longer to try and see to it that they get stabilized and that their family's more involved, or they get to the appropriate place to be cared for properly. Sometimes we end up going into a guardianship case. I'm sure everybody's hearing a lot more about guardianship here recently. The issue with guardianship is needing to have two physicians or professionals that are listed, some social workers, who can make statement that the person is unable to comprehend and to understand caring for themselves and what they need. There's financial guardianship, which is a guardian of property. And then there's also a guardian of person, where someone steps in to make medical decisions, habitation decisions, those types of things. What happens is we all hope that family steps in and makes decisions. However, when that does not happen, or there's no family able or willing to step in for someone, then we may get the referral and we may end up having to work with guardianship. We deal with people who are determined to need a guardian from age 18 to up to 65 years of age. MAC deals with people who are, when they are determined to need a guardian, 65 years of age or older. Once we get guardianship of someone, we keep that guardianship most of the time. There are rare exceptions where we found that someone, once they got the medical attention and the stability and the care that they needed, actually didn't need a guardian anymore. But that is not the usual way things happen. Usually we keep guardianship cases till the end of life, or until there's a transfer. Possibly someone moves, we may transfer to a different jurisdiction. There's a program called Social Services to Adults. It's SSTA, and that's a voluntary program. where we work with people to address whatever needs they may have. Sometimes they have housing needs. That's not to say that we're going to find housing for someone, but we can assist. The problem is that there's a lot of need and not as many resources as there is need for resources, which I'm sure everyone here is well aware of. So we can help in that regard. There's case management, there's a crisis intervention. Oftentimes we'll take what we refer to as an information and referral. So we can just pop out, see somebody very quickly, give them some resources, or even just call them and talk to them about resources. All of these go through our intake department. Now, what I'll say about the intake, they're going to want quite a bit of information if you call in. They're going to want to know where the person lives, a phone number, their date of birth. These are the things that we need to really get started to decide if we're going to accept the referral. And we do not accept every single referral. We have to weigh the issues that are brought to us and determine whether it's an appropriate time for us to intervene. We do try and do whatever we can to give people information when they call in with an issue, but sometimes, especially with the adult protection piece of it, we don't necessarily meet the criteria needed to open an investigation. So I wanted that to be made clear, because sometimes when a referral is made, people assume we're taking all of the referrals. And trust me, Wycomico County, all of the counties in this area are experiencing a lot more referrals than we did 10 years ago. So again, as people age, as people continue to be homeless or need some kind of extra assistance, our referrals are increasing substantially. We also have a program for in-home aid service. We have a limited budget. Right now, we have a very large wait list. But this is where we would have case management, maybe the social services to adults, or maybe the adult protection continuing case management. And we contract with agencies in the vicinity and in the community to provide services. Some jurisdictions have their own staff, or they do some of their own staff, as well as using contractors. But we are on a budget. And again, the budget doesn't always increase to match the need. So right now we have a large wait list. The in-home aid service provides personal care, chore services, those types of things, but we're right now limited to the most severe cases in the community, just even to assess on the wait list. So that's one of the programs. We have another program called Project Home, and we would love to expand that program. It kind of puts the in-between piece for people who need assistance. They can't afford long-term, or they can't afford assisted living prices, and they don't qualify with a medical need to go into long-term care. Project Home, we have providers, and it's a foster care model, an adult type foster care model, where people in the community bring people into their homes for them to live as a family member. And the state assists with that depending on income levels. But it is very, very important to bridge that gap for people who need assistance but don't have the finances to be able to private pay for assistance. We would love to have a shout out based on anybody who would be interested. Please reach out to us. This again is another program that not all jurisdictions have. Some have chosen not to or do not have persons that are interested in becoming providers. Along with that, we have the residents where if it works, they go into a project home and then we oversee their case management. We work with the project home provider that we have licensed. We continue to oversee their licensing, and we visit and case manage with the individuals who live in the home with that provider. Again, anybody who knows anybody who would be interested, I know Wycomico County is looking for homes. So if you are interested, we would love for you to reach out to us and we can talk to you about what this program can provide in the community. And finally, we also have respite. You've heard a lot of agencies talk about respite. We utilize respite. Sometimes we utilize it in an emergent basis, but it's really to give the caregiver a break. So there are criteria, financial criteria. A lot of times, again, we use an agency to provide the respite. That or the person can pick someone to provide respite. We do a general background check because we want the person providing the respite to be someone that is safe to be caring for someone who may not be able to protect themselves. So we do a general background check, and then we can provide up to 2 weeks of overnight stay in a year as long as we have the funding available. Or we can do hours at a time where it gives someone an opportunity to go play bridge with their friends or go play poker if you'd rather. You need to take a break and know that there's somebody caring for your loved one. So we do have that service also. Again, we try and provide these services to everyone, but we do not always have the funding readily available. If we don't have it, we try and work with you to find some other remedies for you and some other means of assistance. So that is really a lot of different services, and my staff works really hard to try and do the best that we can and to refer to other places as necessary. You can call locally for us is 410-713-3900 or the 800 number, which is 917-7383.
Hey, wonderful. Thank you so much, Kathy. A lot of great information. Could you put that telephone number into the chat box, please, for people who may be interested? Or if there's a website where they can go to kind of search out all the different programs would be helpful as well.
Thank you.
Hi.
Sure thing.
Yeah, thank you. Our final panelist is Sandra Gay. She is with Maryland Access Point Assistive Technology at MAC Incorporated. She's going to present on assistive technology and the caregiver. With her role at the MAC office, Sandra has the opportunity to talk with seniors daily about how assistive technology can change their lives, and I'm sure that's what she'll talk about with us today. Thank you for joining us.
Oh, hey, Sandra, you are muted.
Of course I'm muted. I can do assistive technology, but IT, that's something a little different, you know. You got to have humor in these situations. So I want to try to share my screen and want to talk about what we do here in AT. So our mission here at MAC, we assist and advocate for an aging population to live with dignity. It would help if I changed the slide. To assist with dignity to thrive in their homes and communities. I have 8 years experience in assistive technology. Katie Clatterbuck, my colleague, she's an OTA. She has 11 years experience. MAC Incorporated serves all 4 lower shore counties. That's Dorchester, Somerset, Wycomico, and Worcester. MAC was established in 1972, was one of the first 5 area agencies on aging in the nation. And inside MAC is the Caregiver Resource Center. Inside the Caregiver Resource Center is the Assistive Technology Center. And our mission is to keep seniors in their homes as long as possible, as safely as possible, and doing it with dignity. And that word dignity is very important to what we do. Our goal here in AT is to educate as many people as possible about what assistive technology is and what it can do for your life. Our focus, research, education, and it all starts with conversation. Some of the ways that we do that, we do targeted outreaches. Just recently, we spoke with the Parkinson's Support Group. We have monthly conversations with our 3 Connections Senior Center programs at all of our locations. We also work with the Maryland Living Well Center for Excellence in their Stepping on Falls Prevention program. We have an AT monthly newsletter called Max Smart Aging. And if you want to receive that, you can go to our website, which is macinc.org, go to services provided, and click on assistive technology, scroll to the bottom, fill it out, and then you too can get the newsletter. We also do a lot of video series teaching seniors and their caregivers about how assistive technology works and how to set it up. We've done setup made easy, handy dandy, as well as how to for seniors. Our videos can be found on the MAC YouTube page, which is MAC Inc. Delmarva. They also go on Facebook and the MAC website, again, macinc.org. Another way we try to attract visitors to our AT Center is with our featured item of the week. What we do, we highlight an item each and every week. It's something different. We talk about what it is, what it does, and where you can purchase it, because we don't sell anything here. We help people come in, find different devices that hopefully can help, and then where they can purchase it. And again, like everything in life, one size really does not fit all. It's about personal choice. It's about what works for them, and it's about what they want to do and what meets their budgets. We also work one-on-one with a lot of our seniors, helping them to learn Android and iPhone, Apple devices, whether that's a phone or a tablet. There's a lot of great apps that can help. One of my personal favorites, Live Transcribe. There's nothing better. But we have a volunteer that actually comes in and works with our seniors one-on-one, teaching them how to use their smartphones. It's very popular. We want to show you some of our favorite items, and my colleague Katie Clatterbuck is going to be our Vanna White today. So we're going to showcase a few items. Behind me, we have some shirts that match what you should be seeing on your screen. Tommy Hilfiger was one of the first major name designers to make adaptive clothing. The shirt that Katie has there, it's magnetic. which is fantastic. So if somebody has a hard time fastening, whether that is from Alzheimer's or something else, that shirt can easily be fastened via the magnets. Now, if there's a pacemaker, you can't use that. So we got thinking, well, what can we use if somebody's got a pacemaker or if they can't afford an expensive Tommy Hilfiger shirt? So we went to Walmart. We bought a $5 shirt and we adapted it ourselves by using Velcro so that it still gives us the same mannerisms of fastening without the magnets. And then we even did a little more investigating and found some do-it-yourself magnetic buttons. You would need a caregiver to help put the buttons on the shirt because they are very tiny and stiff. But a pack of 9 buttons costs $30 as opposed to one shirt at $70. And again, it's about personal choice, but that was one of the things that we've done. Another, when we talk to clients and there is some dementia, wandering is always a concern. So we did some work. We created a display door, and we have back behind me, we have this alarm. We keep the case of it off so you can see that it's just 3 batteries. But when the door opens, it's going to be loud. It lets you know that your loved one has wandered. You can get a 2-pack of these at like Harbor Freight for like $8. That's an easy way to help the caregiver feel safer about the loved one trying to wander away. So that's one of our favorites. Medication management is always very, very popular. It's a conversation that never stops. There are a lot of medication management systems. There are lock systems. There are non-locking systems. And as one of our other panelists mentioned, some people with Alzheimer's are still very functional. They just get a little confused here and there. And one of the ways they may be able to manage a standard pill box, but they can't always remember what day it is. This one is really cool in that when it's time for your dose of medication, it will light up. The day will light up and flash and beep. So you know that you need to come over and take the medication for that day. It's called the MedQ pill box, and it's hard to do upside down. But it is absolutely fascinating how it actually will light up on the day that you need to take the medication. So that's pretty neat. Again, personal choice comes into play. Some people don't know, and one of the first things we ask when we're working with clients with Alzheimer's and they're talking to us about their loved one, and we say, how is their appetite? Are they eating? And a lot of times the caregiver will say, no, especially your leg, they don't seem interested in food. They're not eating anything. I put the plate down. And one of the first questions we ask, what color is the plate? And we get a quizzical look back. Usually it's a white plate. Why? People with Alzheimer's have some depth perception issues. And so the red plate stands out. Not only is it red, it is also a scoop plate, which makes it easier to put food on the utensil. But I have one lady in particular, she went and bought some inexpensive, colorful plates, and she said, holy cow, mom's actually eating again. So it wasn't that mom had necessarily lost the appetite, she just couldn't see the food. And this is one of those things that it's a relatively easy, inexpensive fix. One of the other items, we are really into smart home technology. The Echo devices, man, they're fantastic. If you've got Wi-Fi, you need an Echo device. The Echo Show, which we have back here, it allows for drop-ins. So if you are the caregiver for someone with Alzheimer's, and let's say you live in another town, you can't get to the house all the time to check on your loved one, you can do drop-ins. And by doing so, it's like a video call, but your loved one doesn't have to push any buttons. They don't have to remember how to do anything. You just do a drop-in via the app on your cell phone, it will show up on their screen and you can have a face-to-face conversation. So not only are you hearing their voice, you're actually seeing them. And a lot of times us seeing our loved one with Alzheimer's, we can tell when something is a little off. Another really neat feature with the Echo Show is that you can put photos on it. So you can do reminiscence with that by doing photos of memories. And so I have another client who is doing that with his mom, and it is making a huge difference. So the Echo Show, again, you wouldn't necessarily think it would be a tool for Alzheimer's, but it can be. It's about thinking outside the box. One of the things that we found with people with Alzheimer, they continually ask, what time is it? What day is it? They're not sure. The Hello Robin clock, as seen back here, it is a talking clock. She's a little hard to hear, but she is a talking clock, lists the day, whether it's morning or afternoon, the time. You can also set alarms on it. It is a dementia day clock. So it is a fantastic item for those with Alzheimer's. Again, we talk about people wandering. That's the word I'm looking for. A bed alarm system. And look, I already hit my, let's go back to that one. A bed alarm system. This would be placed in the bed under the sheets. I have it upside down. Let's turn it that way. This is going to be loud. So I'm just warning you now. So we'll plug it in briefly. And as soon as the pressure is removed, you can make it play, which is hideous, or which is even louder, it can alarm. So that is extremely loud, but it also allows the caregiver to get some rest, to know that it's okay. They can rest, because the caregiver, again, talking about caregiver burnout, it is a real thing. And having a caregiver who can get a halfway decent night's sleep sometimes can be very difficult because they're worried about whether their loved one is wandering, whether they've fallen because they tried to get out of bed. This will notify as soon as they get out of bed. So it makes it very easy. If you want any additional assistance, our phone number is 410-742-0505. Of course, you can always get us at macinc.org. And thank you very much.
Hey, well, thank you, Sandra. That was a lot of information in a short period of time. So thank you.
I could talk about it all day.
Yeah, no, you did great. Thank you. All of our speakers, thank you so much. I don't see any questions in the chat box for anyone, but we do have about 10 minutes looking back at the time that was available to us. So if anyone has any questions, you can either put it into the chat and I can ask it, or you can take yourself off mute. Erica and 3 others look like they have their hands raised. Michael, how do I access those individuals, or do they just take themselves off mute?
Here, I'm getting to them.
Okay, great. Thank you. When you come off mute and ask your question, please also identify which presenter the question is for. And if all of our presenters could please take them, show their videos so that you're here. Thank you.
All right, I'm going to go ahead and allow, I think Rebecca has had her hand up the longest. I'm going to go ahead and allow you to talk, Rebecca. So you can go ahead and ask your question. You just have to unmute yourself. Rebecca, do we still have you there? All right, I will switch to somebody else. I'll come back to you. Let's remove that one. Let's go with Erica. So I'm going to go ahead and allow you to talk. If you want to unmute yourself, you can ask your question.
Yes, I just wanted to say, I'm referring to Ms. Mutzberg's presentation. My name is Erica Folks. I'm actually the program administrator for Project Home and Project Home Adult Foster Care and Social Service to Adults at the state level. So I would like to just drop my information in the chat. I tried to do that, but the chat was disabled. So I just wanted to let folks know, if you have questions If you're calling from other areas of the state and you have questions about Project Home or social services to adults, I can leave my information in the chat. Thank you.
All right, yeah, Erica, I'll reach out to you after the conference is over and get your info, and I can go ahead and send that out when I send out everybody else's information with the presentation information and everything.
Okay, thank you.
Sure, no problem. All right, let's go with Grace next. So Grace, you can go ahead and unmute yourself and ask your question.
Can you hear me?
Yes.
Oh, okay. Thank you. So my question was for Lauren Blair. I
Yes.
wanted to know, are there different levels of hospice care, like depending on whether it's offered in a hospital as opposed to, hospice care center like yours? Um, uh, and the reason for my question is because my experience in the hospital was much that hospice care was not like anything that you described.
Mhm. So it depends on what hospital we're talking about and which hospice as well. So
Mhm.
we're contracted with Title Health to provide general inpatient care there if needed. And that is, we really try to serve our patients either at their homes or in their nursing homes or wherever the case may be. But occasionally you have patients who are not able to be transferred to their home or maybe to one of our inpatient centers who will need that care right at the hospital. But the majority of our patients are served elsewhere. The majority are really served at home.
Mhm.
Sometimes we'll have patients, of course, at the lake or standstill house, just depending on, like you said, what level of care they're needing and where they're able to be. We have a lot of patients who go to coastal hospice at the lake or to standstill house for a short period of time because that is kind of like a hospital for hospice patients, and then return to their homes or nursing homes, assisted livings, wherever that may be.